Hello, everyone. Today, we're very pleased to welcome Dr. Zouves with us. This is going to be part 2 of his webinar about maximum science and holistic IVF. So let me just quickly reintroduce Dr. Zouves for people who haven't met him in the first time. Okay, Dr. Zouves has been involved in IVF since he came to North America. He's helped thousands of families around the world realize his dreams. After studying medicine at the University of Cape Town in South Africa, Dr. Zouves completed residencies and fellowships in OB/GYN and general surgery at Royal Colleges in London, England. In 1981, he moved to Canada and he became Canadian board certified in OB/GYN. He completed his training in infertility and reproductive endocrinology at the University of British Columbia. He served at University of British Columbia's IVF program as medical director before moving to San Francisco in 1992 to practice. Okay, in 1999, Dr. Zouves opened up his own clinic called Zouves Fertility Center, where he and his team take a progressive approach to fertility, combing the latest technology advancements with holistic modalities to aid in achieving individual and family goals. Okay, and as well, Dr. Zouves is a longtime friend of Donor Concierge, and we're pleased to welcome him to talk about holistic IVF.
Thank you very much, Cynthia. And as you mentioned, this is the second part of the seminar. The first part was on optimum health. Today's on maximum science. So why don't we lead off? So what do we mean by holistic IVF? So what we mean by holistic IVF is that we start with optimum health. We have to have our egg and our sperm providers and our carriers in the best possible shape. And then to that, we add the maximum science. So last webinar, which is on your YouTube channel at Donor Concierge, was optimum health. So today, we're going to focus on maximum science. We're going to be talking about laboratories. We're going to be talking about breakthroughs like flash freezing, preimplantation genetic testing, isolation of the best sperm. And then we're also going to talk about the immunology of pregnancy. So what we do is we start with an egg and a sperm, we make an embryo, and hopefully we make a baby for each and every one that comes through. So we're going to start with the maximum science here, and we're going to talk first about the state-of-the-art laboratories. Now, here at ZFC, we have 3 distinct labs. We have one lab where we run the in-cycle hormonal analysis so that we can get our results back within an hour or 2. We also have an IVF lab where we put the egg and the sperm together. We make embryos, we biopsy and freeze them. And we have a third lab called the genomics lab where we send the cells from the embryos that we biopsy, and we do the analysis by next generation sequencing right here on site. So let me show you some pictures inside our IVF lab. Here is a shot of one station within our IVF lab. And this station, all of this equipment here, will allow us either to inject one sperm into the egg, which is called ICSI, or it will allow us to do biopsy of a 200-cell embryo. And if you look at the next slide, you'll see that we have 2 stations like this side by side, and we have a total of 4 stations like this in our lab. So on the one side of the lab, we could be fertilizing eggs and doing biopsy. And then on the other side of the lab, we can be doing the PGT. Now, this is a bank of incubators, and you can see in this picture here, we have 15 tri-gas incubators. We have enough incubators so that each couple, each patient has an incubator dedicated to their gametes, because we don't really want to be opening the door to look at embryos on the top shelf and then disturb the environment for somebody else's embryos on the middle or bottom shelf. So these are tri-gas incubators. And if you look at the top left-hand corner, you'll see emergency power. We have a 150 kilowatt Caterpillar generator on the back lot here. So as soon as the power goes down, within 5 seconds, we're on full power for all of our incubators and all of our vital installations within the clinic. And even for the electronic equipment, we have a battery bridge so we don't lose any scientific information. So the first major breakthrough we're going to talk about today is vitrification. And vitrification is Japanese technology, and it's a flash freeze. So the freezing happens so quickly, and we go from room temperature to minus 196 Celsius in milliseconds. And this way, there's minimal ice crystal formation, and that's what takes the survival of either eggs or embryos that you're vitrifying way over 90%. And just for reference, when we used to freeze eggs with the old-fashioned slow freeze, the survival was only 10%. So really, vitrification has been a game changer for being able to freeze not only eggs, but also embryos. At Zouves Fertility Center, we've been pioneers in vitrification now for more than 6 years. A pair of eggs is placed on the end of a nylon ribbon and flash frozen in milliseconds. This is vitrification. We are now seeing better than 95% survival when eggs are vitrified. With egg vitrification now, a woman can clearly stop the biological clock. Egg freezing has been all over the news recently, and for good reason. While men continue to produce sperm on a regular basis almost throughout their lifetimes, a woman is born with all the eggs she will ever have. At one time, this put women at a great disadvantage, but not anymore. For women who are focused on their careers, haven't found the right partner, or are not yet ready to start a family, egg vitrification is the perfect solution. Many women assume that egg freezing must be a lengthy and time-consuming process. In fact, after approximately 2 weeks of injectable medications, culminating in a 20-minute egg retrieval procedure, the eggs are in the lab and vitrified and ready to be stored. For some of our patients, this has now come full circle because we've been able to thaw vitrified eggs, make embryos, and allow them to have the baby they've always dreamed of. So the second breakthrough we're going to talk about is Preimplantation Genetic Testing, or PGT. So let's look at the next slide. The second breakthrough is PGT, or Preimplantation Genetic Testing, and this allows us to select the best embryo for transfer. Now, about 95% of the PGT that we do is for aneuploidy, or abnormalities in the number of chromosomes. About 4% is for single gene disorders, and less than 1% for structural rearrangements, also known as testing for a balanced translocation. We have been leaders in identifying the healthiest embryos for transfer since 2001. That's when we started doing embryo biopsy for the purposes of preimplantation genetic screening. Now we are proud to offer next-generation sequencing, which is a game changer, which not only helps us predict and diagnose disease, but also helps us select the healthiest embryos to give our patients the best chance of success. Preimplantation genetic testing allows us to test all 23 pair of chromosomes and also to identify single gene disorders that may run in families, thereby enabling us to deselect those that carry the disease. The platform that we use now is called Next Generation Sequencing, or NGS. Now, when we started doing biopsy of embryos in our program back in 2001, we could only remove one cell from an 8-cell embryo. And when we did the analysis, we only had one data point per chromosome to work with. Now, over the years, genomics has progressed to the point that we can now look at 1,000 data points per chromosome. This allows us to be very accurate in knowing not only whether a whole chromosome is missing, called a monosomy, or whether there is an extra chromosome called a trisomy, but we can also see small duplications and deletions in an individual chromosome. I'm going to show you a short video of how we obtain the 10 cells for testing from a 200-cell blastocyst on day 5 or 6. So here you see a 200-cell embryo, a blastocyst, on day 5 or 6. The clump of cells on the left-hand side is called the inner cell mass, and that is what actually goes to make the baby. Here you can see with a fine needle, the embryologist draws fluid out of the blastocele cavity, places it between the outer shell and the rim of cells that are going to make the placenta. And then we take a laser and we make 2 pulses, which give us a really clean cut in the shell. And then with micro manipulation tools, our embryologist is going to pass a fine glass catheter through the hole. And we're then going to, with very gentle suction, draw up about 10 cells from the placental precursor. Here you see the cells being drawn up into the pipette. And then again, we're going to use the laser. We're going to make a few pulses across the neck of this little bag of cells here. And then that'll break off. And then those cells get sent to the lab for analysis. And you can see here the embryo doesn't collapse after we do the biopsy. And in fact, if you continue to grow it, the hole will seal and it will re-expand. But we will now take these embryos and put them straight into the flash freeze and into storage while we wait for the results. So this is what the research shows. Now, it isn't fair, but you can see from the graph that as the age of the egg increases, the percentage of embryos that are transferable decreases. You can see that under age 35, the chance that an individual blastocyst is transferable is approximately 68%. Similarly, when the egg provider is age 35 to 37, the number is 60%. At age 38 to 40, approximately 42% of embryos of blastocysts are transferable, while at 41 to 42, we're down to 22%, or approximately a 1 in 5 chance. Now, from 43 to 45, the number is around 17%. And unfortunately, as we get to age 45 and above, the number does fall off a cliff. And after 45, the chance of an individual blastocyst being normal is closer to 1 to 2%. Now, this is why it's so hard to make a baby for someone with their own eggs once we get to age 45. So what this means for us is that time is of the essence, and we need to apply the latest technologies and breakthroughs to help our patients achieve success. So as you saw on the slide, it's not fair, but as the age of the egg increases, so the percentage chance that any blastocyst that we make and test is going to be normal. So you can see from under 35, we're nearly at 70% chance that each one is normal. And when we get close to 45, we're down to a 1 in 6 or a 17% chance. And after 45, that number drops to single-digit percentages. Additionally, we don't have a lot of time here because you can see that in utero, there are about 6 million precursor eggs between both ovaries in the fetus. By the time we get to birth, we're looking at down to 2 million. And by the time we get to puberty, we're at about 250,000. So you can see that the egg numbers are dropping quite dramatically. And of course, that's why it's so hard to get a baby for somebody with their own eggs once we hit 45. So we've spoken about making embryos. We've spoken about biopsying embryos. When we go to choose the sperm, we're going to talk now about this third breakthrough, which is called Zymot. And this is how we can actually home in and pick the very best sperm to inject into each egg. So remember, we take an egg and a sperm, and this is how we choose that sperm to make that embryo and to make that baby. Remember the slide? We start with an egg and a sperm. We try to get the best eggs and sperm through starting with optimum health. And remember, when it comes to eggs, the age of the egg is probably the single most important predictor of outcome. But what about the sperm? Up until recently, we did not have a reliable method of selecting the very best sperm for injecting into each individual mature egg. I'm going to share with you the third and most recent major IVF breakthrough called Zymot. This is a revolutionary method of isolating the best sperm And I'm proud to say that at ZFC, we have embraced this technology and use this to isolate the sperm to choose for intracytoplasmic sperm injection, or ICSI, for all IVF cycles. So what is Zymot? In the next few minutes, I'm going to show you how we go about selecting sperm using this method versus our previous method of sperm selection, which relied on spinning the sperm and had been in use for more than 20 years. Wherever you choose to do your IVF cycle, you should be sure that the clinic uses the Zymot process for sperm selection. This animation will show you how we start with an egg and a sperm, both nurtured through optimum health and carefully chosen, to make an embryo which we go on to test and freeze. Because 50% of infertility cases are linked to the male partner and sperm health, the Zymot selection process is an integral part of your fertility equation. Zymot mimics the process of natural selection and allows us to pick your champions. So this is what the Zymot sperm separator chip looks like. The principle behind the chip relies on the most vigorous and normal sperm being able to find a way through a membrane with very fine micropores, allowing us to choose from the very best sperm in the batch. So the sperm sample is drawn up into a small syringe and gently injected through the inlet port. The sperm then swim along the lower chamber, and the best sperm then find a way through the micropores from the blue area into the lavender-colored upper space. And this is where we then choose one great sperm to inject into each mature egg. Once we have selected your champions using the Zymot technology above, we will then inject one single chosen sperm into each mature egg. Now it's remarkable that the sperm is the smallest cell in the body and the mature egg is the largest cell in the body, and together they make a baby with characteristics from both gamete providers. So here you see a fine glass needle. The embryologist draws one chosen sperm into the needle. We hold onto this mature egg with a glass pipette, and we inject this fine needle through the outer shell and also through the inner membrane into the yolk or cytoplasm of the egg. Here you see we're drawing back on the syringe just to be sure that we've actually gone through the inner membrane. And now we're going to inject this chosen sperm right into the yolk of the egg. There you see the needle comes out, and you might expect that the egg might collapse, but it doesn't. It behaves like those Michelin run flat tires. The hole seals, and this egg now goes back into the incubator. It's fertilized, and then we watch it and grow it all the way to day 5 and 6. So next we're going to talk about ERA receptiva, otherwise known as a mock cycle. So ERA is one half of the test, and the receptiva is the other half of the test. Today we're going to be talking about mock embryo transfer. By the end of this, you will know what it is, how we do it, and how it may change our plan for transfer, and also who should get it. So what is a mock embryo transfer? The mock cycle is a dress rehearsal. You do a biopsy instead of actually transferring the embryo. You divide the tissue that you remove into 2 samples, and you do an ERA test on one half of the sample and the receptiva test on the other. Now, in our program, we test all embryos, so at least we take this 70% off the table. So we are now left with about 30% of normal embryos that are transferred that do not implant. Now, unfortunately, a large proportion of this 30% is still unknown to us, but we know that we have to check the physical uterus, we have to check for clotting, and in our program, we check for immune activation. So let's look at the ERA test. This test looks to find the window of implantation. Now, 90% of women have a predictable receptive window, and this test can be performed and calculated in either a natural or a controlled cycle. Now, 10% of women have a displaced receptive window, which would either be early or late, and based on the ERA test, we can then calculate that woman's personal window of receptivity. So this is the ERA test in both a natural cycle and a controlled cycle. If you look at the natural cycle, you need to identify the LH surge by having the patient test her urine with a dipstick, and by also doing ultrasound to monitor the size of the dominant follicle and to look at blood tests, including estrogen, LH, and progesterone. Now, once you identify the LH surge, you want to do the transfer or the biopsy at about 168 hours from the HCG trigger or the LH surge. Now, if you're doing a hormone replacement cycle, an HRT cycle, where you suppress ovulation and then you add estrogen followed by progesterone, you want to do the transfer or the biopsy 120 hours after you initiate the intramuscular progesterone. So let's talk about the receptiva test, the second half of this mock cycle. So the receptiva test detects inflammatory conditions that can cause implantation failure. On the one hand, we're looking for the BCL6 gene, which is a biomarker for inflammation, which is almost always secondary to endometriosis. We're also looking for the biomarker CD138, which is a plasma cell, and when seen in clusters, occurs secondary to endometritis. How do we go about treating abnormalities within the receptiva test? If the BCL6 marker is equal to or greater than 1.4, then we do need to treat this elevated BCL6 level, which is usually indicative of endometriosis, which could be microscopic or overt. And we would treat this with an 8-week course of the GnRH agonist, and we use Depo-Lupron. If we find abnormalities in the CD138 biomarker for clusters of plasma cells, the treatment is a double antibiotic, doxycycline and metronidazole, for 2 weeks. So when should one do a mock cycle? When there's been a history of recurrent pregnancy loss, this would be an indication. A patient with a failed pregnancy after the transfer of a euploid embryo, and a patient who may have a very limited number of embryos available, and you want to make sure that the receptive window is where you expect it to be, and that there is no inflammatory or infective situation which may cause you to fail with one of these very limited number of embryos that you have.
So now we're going to talk about the mystery of the immunology of pregnancy. Now, an egg gets together with a sperm and it makes an embryo, and that embryo will ultimately make what is known as the conceptus. And the conceptus is the fetus and the placenta. Because even when a woman supplies the egg, there's always going to be a sperm required to make an embryo. So a woman is always going to be genetically different from the embryo that she carries. So let me just show you this following clip.
Now, we talk about pregnancy being a miracle. It is, and even more than we realize. The egg and the sperm get together and they form the conceptus, which is the fetus and the placenta. And what makes this a miracle on top of a miracle is the fact that the conceptus is genetically a mix of the sperm and the egg. It is exactly like a transplant. It is not identical to the tissue of the woman who carries the baby. The immune system patrols looking for invaders, which could be pathogens or tissue that is not self. So how is it that a woman can nurture a genetically different being inside of herself without rejection? If you think about it, we cannot do things like organ transplants without having a close tissue match and without taking immunosuppressant drugs. So how do women do this? So women have evolved a remarkable ability to shield the developing baby from immune attack. Now, if this elaborate method of protecting the transplant from being rejected does not work perfectly, it can either lead to failed implantation, early pregnancy loss, or later on intrauterine growth restriction called IUGR, or pregnancy-induced hypertension called PIH. If these three mechanisms work well, then the pregnant woman is in the nurturing or TH2 state, whereas failure of any of these three mechanisms could move the patient into a TH1 state, which is hostile to pregnancy. The good news is that we can do testing which will tell us where a woman falls on this spectrum and apply the necessary treatment. So sometimes infertility or recurrent loss is due to immune activation. And here are some of the tests that we can do to see if we are in the TH1 dominant state or not. So here you can see the tests. We can test for anti-thyroid antibodies. We can test for anti-phospholipid antibodies. And we can also test for cells called natural killer cells, which are the soldiers of the immune system. They are dispatched to attack either a pathogen or some cell that the body wants to get rid of. And they produce toxic chemicals called cytokines. And the two that are most important in reproduction are TNF-alpha and gamma interferon. So if we identify and find these antibodies and cells and cytokines present, they are treatments that we can apply.
At what stage would you recommend intended parents consider using third-party fertility?
You know, third-party fertility in this situation basically covers either using a gestational carrier or else using a donated egg or a donated sperm, or any of the combinations that may be required by an individual patient. So, at what stage do we recommend using a gestational carrier? Now, for some people, it might be an absolute. A woman may have no uterus, or the uterus may be destroyed, or it may be a man having a baby who requires a gestational carrier. So it could be absolute. It could also be relative. Maybe a patient or a couple have tried many transfers. They've done testing. They've transferred normal embryos. They continue to have recurrent failed implantation or loss. Or a woman may have a medical condition which precludes her from carrying a pregnancy safely. And so, people in those situations will know whether they have to go right to a surrogate or whether, they're going to try themselves for a while and then after repeated failure, then resort to a surrogate carrier. With respect to the donor egg, we're all hardwired to want to use our own genetics to reproduce, but at some point it may be an absolute. Somebody may have lost their ovaries through chemo or surgery. Somebody may have been born without any eggs in their ovaries, or somebody might have just run out of runway here and become perimenopausal or menopausal, in which case you'd then have to resort to a third-party gamete like a donor egg. And of course, those can be frozen or they can be from a donor that you recruit who goes through stimulation and retrieval. Now, donor sperm is a little different, and it has changed a lot in the last few years because at this time, obviously, there may be some absolute reasons. If somebody's unpartnered, a woman is unpartnered, there's no sperm provider, she may need donor sperm. But given that we can get sperm from the testicle directly with very low sperm counts, it's quite rare that we need donor sperm in that situation. But there are a few situations where a man may have absolutely not even one sperm, even in the testicle, and then donor sperm becomes necessary.
So, and then what would you recommend to intended parents who are not working with your clinic?
So I think if you look at the two parts of these two webinars that Donor Concierge have put together, you definitely want to be starting with optimum health for anybody providing eggs or sperm or going to be carrying. So you want to be familiar with what healthy lifestyle, supplements, diet, BMI. You want to be familiar with all of these and make sure that the clinic that you're working with, is supportive and encourages the participants to be as healthy as possible. On the other side, you saw today the maximum science. You want to know that the clinic you're working with is going to be looking at stimulation, looking at picking the best sperm, making the best quality embryos. And I think in this day and age, you want to be testing each embryo that you produce, each blastocyst, because you only want to be putting in one normal embryo at a time. I don't believe in putting in an untested embryo, because if it's not normal, it's destined either to fail or to miscarry, or worse still, to give you an abnormal baby that you may only pick up at 16 weeks or tragically even at birth. So you want to look at a clinic that's embracing, both the optimum health and the maximum science.
I found your maximum science video so informative. It's nice to see what happens behind the scenes in the embryo formation and embryo creation part. So if you are using an egg donor or a sperm donor, what can you do to improve your chances of success?
So if you're using an egg or a sperm donor, number one, you want to look through the profile of of the gamete providers. Now, often the sperm will already be frozen in the bank, so you have to trust that that person was following a healthy lifestyle and not doing drugs and all sorts of other things. You want to also know that the donor you're using has a good lifestyle habits. All gamete providers will be tested for single gene disorders. They'll have carrier testing in the past, and we try to have egg donors providing fresh eggs follow as healthy a lifestyle as possible. They do need to have a normal BMI. We put them onto supplements and no bad habits, no smoking, no bad habits leading up to providing the eggs.
I'm sure a lot of intended parents would like to get in touch with you to find out more information. How do you do that?
Sure. I think there are many ways that you can reach us. The first link here is actually a webinar that incorporates the whole of Holistic IVF. It does the optimum health, and it also does the maximum science. The second link is our website. And the third link is our YouTube channel, just like Donor Concierge has a YouTube channel. And the QR code at the bottom will take you to that full webinar that does optimum health and maximum science.
Dr. Zouves, thank you for your time. It was wonderful and so educational. It's always nice to have you here. And just to wrap up, Donor Concierge, again, we're great friends with Dr. Zouves and his clinic. If anybody needs an egg donor, sperm donor, surrogate, you're welcome to give us a call. We're happy to have a consultation with you and just guide your way through your third-party fertility journey if you need so. All right. Thank you very much, everyone.
Thank you.